Welcome to this Step 2 clinical knowledge review on anxiety disorders test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for anxiety disorders and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the psychiatry and behavioral science sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for anxiety disorders on board exams. Second, we will apply specific strategies for questions about generalized anxiety disorder, panic disorder, post-traumatic stress disorder, and obsessive-compulsive disorder. And third, we will master the next best step question format for diagnosing and treating common anxiety disorders. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the duration and trigger framework. When you see a question about anxiety, immediately ask yourself two questions. First, is this chronic worry or episodic panic? And second, is there a specific trigger or is it generalized? For chronic worry, look for excessive anxiety about multiple life domains lasting 6 months or more, with associated somatic symptoms like muscle tension, restlessness, fatigue, difficulty concentrating, irritability, and sleep disturbance. This points to generalized anxiety disorder. The boards test the 6-month duration requirement heavily, so always check the timeline in the question stem. For episodic panic, look for sudden onset episodes of intense fear that peak within minutes. The classic presentation includes palpitations, chest pain, shortness of breath, derealization, and fear of dying or losing control. This points to panic disorder. The boards love presenting these patients in the emergency department with a negative cardiac workup, so make this your first mental framework. Strategy 2 focuses on trauma and intrusion patterns. For post-traumatic stress disorder, look for a clear traumatic event followed by 4 symptom clusters. Intrusion symptoms like flashbacks and nightmares, avoidance of trauma reminders, negative changes in mood and cognition, and hyperarousal with hypervigilance and exaggerated startle. A critical time distinction is that symptoms must last more than 1 month. If symptoms last less than 1 month, think acute stress disorder instead. The boards test this duration cutoff frequently. For obsessive-compulsive disorder, look for ego-dystonic intrusive thoughts paired with repetitive behaviors performed to reduce the anxiety caused by those thoughts. Classic patterns include contamination fears with excessive hand-washing, symmetry obsessions with ordering and arranging, and forbidden thoughts with checking rituals. The behaviors are time-consuming, typically taking more than 1 hour per day, and cause significant distress. The key word is ego-dystonic, meaning the patient recognizes the thoughts are excessive or irrational. These are high-yield board patterns. Now let us go through high-yield stem recognition. For generalized anxiety disorder, the classic stem is a patient with excessive, uncontrollable worry about multiple areas of life for 6 months or more, with associated somatic symptoms such as muscle tension, insomnia, and difficulty concentrating. The worry is out of proportion to actual circumstances, and the patient has trouble controlling it. For panic disorder, the classic stem involves recurrent, unexpected panic attacks, with at least 1 month of persistent worry about additional attacks or maladaptive behavioral changes. These patients often present to the emergency department with chest pain and a completely normal cardiac workup. For post-traumatic stress disorder, the classic presentation is a patient with a history of a traumatic event who develops flashbacks, nightmares, avoidance behavior, emotional numbing, and hypervigilance lasting more than 1 month. The boards may describe the trauma indirectly through the clinical presentation rather than stating it outright. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 32-year-old woman presents with a 6-month history of persistent worry about her job, finances, and family health. She reports difficulty sleeping, muscle tension in her neck and shoulders, irritability, and an inability to relax. She denies any specific triggering event. Physical examination and laboratory studies are unremarkable. What is the most appropriate initial treatment? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. This patient has 6 months of excessive worry about multiple domains with muscle tension, sleep difficulty, and irritability. Normal labs rule out medical causes like thyroid disease. This is textbook Generalized Anxiety Disorder. The 6-month duration and multiple worry domains are the key differentiators from other anxiety disorders. Step 2. Apply the rule. The board rule you need to know is that first-line treatment for generalized anxiety disorder is either cognitive behavioral therapy or a selective serotonin reuptake inhibitor. Both are considered first-line, but cognitive behavioral therapy is often preferred as the initial approach because it has no medication side effects and teaches lasting coping skills. Benzodiazepines are not first-line due to dependence risk. Step 3. Eliminate wrong answers. Fluoxetine is a selective serotonin reuptake inhibitor and is appropriate but takes weeks to work. Buspirone is also an acceptable option, but has less evidence than cognitive behavioral therapy as initial treatment. Lorazepam is a benzodiazepine, which is not first-line due to dependence risk and is only used short-term. The correct answer is B, cognitive behavioral therapy. Here is our second practice question. A 25-year-old woman presents to the emergency department with sudden onset chest tightness, palpitations, diaphoresis, and an intense fear of dying. Symptoms peaked within 10 minutes. Her electrocardiogram and troponin levels are normal. She reports 3 similar episodes in the past month with persistent fear of another attack. What is the most likely diagnosis? Think through this carefully. The key clues are the sudden onset, the normal cardiac workup, and the recurrent nature of these episodes. We will walk through the answer next. Let us work through this answer. First, read the question carefully. The question describes recurrent discrete episodes of intense fear that peak within minutes, with cardiopulmonary symptoms and a completely negative cardiac workup. She has had 3 similar episodes in 1 month and now has persistent worry about future attacks. This is the textbook presentation of panic disorder. Now, why is panic disorder the answer and not the others? Generalized anxiety disorder causes chronic, persistent worry, not discrete episodes of acute terror. The episodic nature rules it out. Acute coronary syndrome is excluded by the normal electrocardiogram and troponin, which is exactly why the question included those results. Hyperthyroidism can mimic panic symptoms with palpitations and diaphoresis, but the episodic nature with a clear peak within minutes and the intense fear of dying point much more strongly to panic disorder. The correct answer is B, panic disorder. Let us review anxiety disorder treatments for the boards because this comes up constantly. For first-line pharmacotherapy, selective serotonin reuptake inhibitors are the go-to medication class for generalized anxiety disorder, panic disorder, post-traumatic stress disorder, and obsessive-compulsive disorder. Serotonin norepinephrine reuptake inhibitors like venlafaxine are also first-line for generalized anxiety disorder and post-traumatic stress disorder. Buspirone is an alternative specifically for generalized anxiety disorder only. The boards expect you to know that pharmacotherapy takes several weeks to reach full therapeutic effect. Now for the key treatment distinctions. Benzodiazepines should be used short-term only for acute anxiety or panic, and are never first-line for chronic treatment. For obsessive-compulsive disorder, higher doses of selective serotonin reuptake inhibitors are often needed compared to standard depression dosing, and the response time is often longer. Prazosin is used specifically for trauma-related nightmares in post-traumatic stress disorder. Exposure and response prevention is the gold standard psychotherapy for obsessive-compulsive disorder. The boards love testing these distinctions, so commit them to memory. Here is our third practice question. A 35-year-old male combat veteran presents with difficulty sleeping, recurrent nightmares about deployment, exaggerated startle response, and emotional detachment from his family. These symptoms have been present for the past 3 months. He avoids crowded places and loud noises. He reports feeling constantly on guard. What is the most appropriate first-line pharmacotherapy? This is a classic post-traumatic stress disorder question stem. Think about which medication class is first-line, and be careful not to confuse first-line treatment with symptomatic management. We will walk through it next. Let us break down this answer. The classic pattern here is a combat veteran with nightmares, hypervigilance, avoidance, emotional numbing, and symptoms lasting more than 1 month after a traumatic event. This is textbook post-traumatic stress disorder. The duration beyond 1 month separates this from acute stress disorder, which is the same symptom cluster, but lasting less than 1 month. Now for the key distinction on each answer choice. Clonazepam is a benzodiazepine, and benzodiazepines are actually avoided in post-traumatic stress disorder because they can worsen long-term outcomes and interfere with trauma processing in therapy. Prazosin is an excellent medication for trauma-related nightmares specifically, but it is not the first-line overall treatment for post-traumatic stress disorder. Quetiapine is an atypical antipsychotic that is sometimes used as an adjunct, but is not first-line for post-traumatic stress disorder. The correct answer is B, sertraline. A selective serotonin reuptake inhibitor is first-line pharmacotherapy for post-traumatic stress disorder, and sertraline is one of only two that have specific approval for this indication. Here is our final practice question. A 20-year-old college student presents with dry, cracked hands from washing them over 40 times per day. She reports intrusive thoughts that she will contaminate others with germs. She recognizes her behavior is excessive but cannot stop. The hand washing takes several hours daily and has caused her to miss classes. What is the most appropriate treatment? This is a classic obsessive-compulsive disorder question STEM. The contamination obsession with hand-washing compulsion is one of the most commonly tested patterns. The key feature here is that the patient recognizes her behavior is excessive. That ego-dystonic quality is what separates obsessive-compulsive disorder from a delusional disorder. The answer is A, cognitive behavioral therapy with exposure and response prevention. Exposure and response prevention is the gold standard treatment for obsessive-compulsive disorder with the strongest evidence base. Selective serotonin reuptake inhibitors like fluoxetine are effective and often used alongside exposure and response prevention. But exposure and response prevention alone has the strongest evidence. Benzodiazepines do not effectively treat obsessive-compulsive disorder. Supportive psychotherapy alone is insufficient for this condition. That wraps up our review of anxiety disorders test-taking strategies for Step 2 clinical knowledge. Remember to review the psychiatry and behavioral science chapters in First Aid and your question bank. Focus on the diagnostic criteria, first-line treatments, and the key distinctions between each anxiety disorder that we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.